Hey everyone, and welcome to the Coast to Coast Plastic Surgery Podcast. I'm your host, Dr. Caleb Steffen. Each episode, I sit down with leading plastic surgeons from across the country to explore surgical technique, clinical decision-making, and the artistry behind aesthetic and reconstructive surgery. Whether we're discussing complex cases, innovative approaches, or the philosophies that shape great surgeons, our goal is to elevate the conversation and help advance our specialty.
I am great. And I just want to thank you for doing this. I think this is great that we're able to just share with people in kind of a low risk type of environment. Maybe this will build and, we'll be able to answer some questions and help some people out.
I would hope so. At first, I was going to ask you if you were being sarcastic, but then, you kept going and I was like, oh, maybe he's saying something nice.
You know me too well. We've known each other since back in residency. It must have been 2012. So good 12, 13 years, I guess now, huh?
Yeah, that's really hard to believe. I've gotten a lot older, but not much balder. I was pretty bald at that time, and you still have all your hair, so none of that has changed, huh?
I have a secret about that, but I'm not going to let it out to the viewers.
Okay, that's okay. This is kind of share what you want to, don't share what you don't want to. Well, tell everybody a little bit about yourself, kind of where you grew up, how you got here, and then, what led you to what you're up to now. We want to hear a little bit about Dr. Zuhlke.
Well, how I got here, I have no idea. This is definitely not where I thought I would be. So I grew up in Madison, Wisconsin, and was there for 30 plus years. Left very briefly for various different activities or work, but really never to any place where I would say that was really my home. It was always Madison, Wisconsin. When I was
Does
16,
Cheesehead apply to you or no?
For sure.
Whatever. Don't care.
We're gonna get to favorite sports teams and stuff. I mean,
okay. Don't jump the script.
Yeah, I know. I'm not trying to, but I want people to understand when I say what I say, because I was a Packers fan and had a Packers coat when Lynn Dickey was the quarterback, and that was like really bad times in Green Bay history. So I've been there before. It was all glory and greatness. So
not a fair weather fan, a true blue, true green and yellow.
I mean, if you knew my personality, it's just I gotta stick with something, and
I do know that about you, actually.
We don't like change. Yeah. So which is funny because plastic surgery is an always changing field. And so True. We definitely have to adapt. Part of doing these types of, talks and things like that just are helping to kind of move the ball down the field, if you will.
Absolutely. So grew up in Madison, Wisconsin. What kind of kid were you? What was Dr. Zuhlke like as a child?
Yeah, so I was actually a latchkey kid. So my mother was a single parent, and we did a lot of things by ourselves and in our neighborhood. The 5 blocks that was around our neighborhood. I grew up on the near east side, and then the north side, which is kind of the white collar side of Madison. And it was good. I went to public school. I went to private school for a year, but just pretty much was in the public school system, and that was good. Madison schools were an excellent, that was one of the great things about Madison, very highly educated community with a big university, and so education was good, especially public education, relatively safe place to grow up. Definitely, there's tones of Ithaca, New York, and San Francisco, and Austin, Texas.
Sure.
Very, very.
You're saying it's a little weird?
It's a little weird. But,
okay.
I live now here in Colorado and operate in Boulder. And so in some sense, it's home. Not to be super negative about the Boulder people.
No.
The Madison people are a little bit more friendly. That's what I would say.
Okay. All right. We will not. If you're from Boulder, please do not watch. We don't want you to. We want to keep the vibe positive. That's funny. So are you an only child? I didn't. Do you have any brothers or sisters?
No, I do. But just to say, we've really enjoyed working in the Boulder community. So
I know you have. He sells me on it every day.
Yes.
Every day I have to work on my wife to move to the Boulder, Denver area to set up practice with Dr. Zuhlke, which I find is quite a compliment. I'm looking forward to doing it. It's going to be good.
Yeah, yeah. So, we to skip way ahead. We eventually settled in the Denver area. We're in the northern suburbs, Brimfield, and working up in this area, and it's been great. It's hard to think about moving away from this area, and the longer we're here, obviously the more relationships we establish. So what was growing up like? Growing up was pretty standard fare. I was in, even though we've talked about Green Bay, I was not a football player. I was a soccer player. So that was big. And I was also did Taekwondo for many years. That was sort of my activities as growing up. I went to high school, and in my junior year, I went abroad and spent a year in Ecuador. And
tell us about that. That's pretty cool.
Yeah. It was very good. Actually, the people that I stayed with, their son had stayed with us the year before. My sister, you had asked about being an only child. I have a sister that's 2 years older. She went to Germany, and so we hosted someone. And then the following year, I went to Ecuador for the year, and that was a great experience and really sort of opened my eyes to a lot of different things. Interestingly, the mother was a dentist and the father was a doctor, and I could probably fill this entire segment with telling stories about the things that we saw and did. Here's two facts.
Give us one. Yeah, give us one or two.
One. Yeah. One. I got a shot in my tush with a glass syringe with a reusable needle, because that was
nice.
That was still going. Yeah, not many people can say that.
Way to go.
We reused gloves and powdered the gloves for reuse.
How did the gloves get cleaned? Like, is it a washing machine scrubbed it? How did
100% not sure? I know.
Just soak them in Dawn for a few minutes and hang them up to dry.
Right. I was very young, and when I think back to those, I'm kind of like, well, you do what you do, right? Right. I mean, it was interesting because at the time, the capital was very much a first world country, but once you got outside of the capital city, it became very much a third world. Environment with very limited access to healthcare. There was a 10 to 15 story building that sat just constructed and not occupied, which in the city where I was living was the government hospital, but they funded it enough to build the building, but then couldn't fund it to actually staff it. And so it just sat empty. Eventually, I think they did move there, but the clinic and sort of hospital that they had was like a 2-story building that was very limited, compared to basically a 15-story modern hospital. So there were some real significant disparities and things that were, there, which it's interesting to take those in as a 16-year-old because you kind of register them, but you're kind of 16. So you're kind of just like, well, not necessarily understanding the full, scope of things. So later in life, and as I went into medicine, some of these things became really more apparent as I looked back and reflected on that time and kind of what was going on and how healthcare was being delivered. So,
was medicine on the horizon at that time, or did it come on the horizon after you went there?
It's funny how my evolution went with. I was very much a delayed gratification saving kind of person. But there was definitely this piece of me that was not sure that I wanted to do medicine. So when I went to high school, the University of Wisconsin had this agreement with the Madison high schools that if you finished in the top 10% of your class, you sort of had automatic admission. And so I didn't look a ton farther outside of Madison, it was a good school, and for a number of reasons, economic reasons, it was the most affordable, best choice, and I could be at home, or in the Madison community. So I ended up going to University of Wisconsin and studying biochemistry and molecular biology. And
Take note, all ye listeners.
thought I was going into industry. I went to University of Wisconsin from 1991 to 1994, finished a semester early and took an internship with Dow Lanco out in Pennsylvania for 6 months. And that was interesting. But the take home on that was that I knew that I did not want to go into industry after that. So I came back to Madison and became a police officer. So I was a police officer for 7 years.
Yeah, everybody wants to hear Dr. Zuhlke's police officer stories. We want something good.
Those are probably the better stories. So
yeah, share those.
Spent 7 years as a police officer, and
I'm sure I have known that, but I did not remember that for this. I'm sure that has come up before because it does sound familiar, but I wasn't thinking of that right now. So I want to hear some. We haven't never really gone into that very much, I don't think.
No, I don't really go into it necessarily. I mean, I'm happy to.
Well, you should, because it's awesome. And thanks for doing that. Thanks for being a police officer, keeping people safe.
So I was a police officer when 9/11 happened, and that was a very sort of tumultuous time in law enforcement across the country. Even though sort of at the end of the day, it ended up being sort of reorganization of how we delivered certain aspects of law enforcement more so than responding to any additional sort of critical events. But it's been interesting how things have sort of gone, full circle. Right. The question that everybody asks is how'd you end up in medicine? That seems so different than law enforcement. And the reality is it's not, philosophically, the people that go into law enforcement are often the same types of people that go into healthcare. Can
you expound on that a little bit for people who aren't going to connect that dot right away? Tell us more about that.
Yeah, their response is usually, I wanted to work with people, I wanted to help people, I wanted to make a difference, and those are sort of universal types of reasons why people go into these types of career paths. So, but then on top of that, when I start telling people about like, what do you do on a day-to-day basis, all of a sudden the light bulb sort of goes off and they're like, So, the reporting is very, very similar, right? So you go out and you get some witness statements from people, you collect the subjective information, you get, just the facts, ma'am. And then you do your objective investigation, collect the evidence. Then you make a charging decision, which is an assessment. And then you do a charge, you basically carry out whatever your plan is, or, you're in the case of law enforcement, if you're going to write them a prescription, you write them a ticket. If you're going to have them come to the clinic, you give them a summons. If you're going to put them in the hospital, you take them to jail. So
all the medical people have already connected that what you just described was a SOAP note, or a subjective objective assessment plan, and that's the way we work up and treat every patient that we see. And I guess that's the way a police officer works up and treats his patients as well, huh?
Very, very similar. So, I mean, it wasn't a huge jump, but the real reason to do to change. I spent 7 years as a police officer, and it was great. I was 22, and then I was 29, and it was great, right? So those are great years where you're able to run after 18-year-old, and then you sort of get to the spot in that type of career where you decide, are you going to become an administrator and police a desk, or are you going to do something else? And so the opportunity was there to go to medical school. I initially deferred after I had admission, and then it was sort of do it or don't do it. And I was concerned that I would age out. So I made the switch. I I left in 2020 or 2003, and I think that watching what has happened over the last 20 years, most people, it's, when people ask, I say it's a great time not to be a police officer. So as stated, I appreciate all the people that are out there, really working hard and doing good work. But it has been a tough time for police officers. And
True.
I've always been very happy to move on to medicine, and never really have looked back as far as, hey, should have I stayed being a police officer? I think you think about that sometimes in the long days when you're remembering your union contract. But I also, laid in snowbanks and stuff, watching perimeters and things like that. So,
That's funny.
you pick what you're what seems like a good and what seems like no fun. So
At some point during that experience, you had to up and take the MCAT, I assume. So what about all these other non-traditional medical people who might be listening? Well, I mean, how did that go? What did you do? Are you the sort of person, I mean, what was that background again? Molecular biology and biochemistry or something crazy? Did you just up and take and be like, yeah, I'm just going to go ahead and ace this thing? Is that how that went?
I mean, I was just
You
like,
don't have to be modest. I mean, that may have been just how it went.
well, I thought, hey, I'll take this thing. And so yeah, there's a lot of stories to that. I didn't understand that medical school was supposed to be a full-time deal. And yeah, so just for the viewers at home, don't try to go to medical school and do other things at the same time. It probably wasn't the best. That wasn't the best start to get solid foundation. So
So you
yeah.
had a side job during medical school?
Well, I mean, I was policing, and so it was, there was definitely, it, I don't even know how to phrase this for the audience that's out there. I mean, I did not, there was something that was conceptually not there for me with all of my co-medical students that, that was their main focus in life. And I was like, well, this will be interesting as you know,
Side gig.
side gig, improve my knowledge. We'll see how this goes, kind of thing. And
That may give you all who are listening a little bit of insight into how smart policeman Zuhlke is and was. That's pretty cool. Everybody sitting there jealous at home, being like, man, I wish I had those kind of brains, huh?
I think probably from my EMS and police experience, because I was doing EMS through this period as well too. I thought that emergency medicine would be a great. Quite honestly, I don't know if you know any of this.
I do know some of it, but
maybe,
refresh me.
yeah. So, I mean, literally, I went to high school. I at the end of high school started doing EMS. I was looking to try to figure out what I wanted to do.
What's
Did an internship
what's EMS again for everybody?
emergency medical services.
I think most of y'all know that, but just in case we get bogged down, and we're going to get bogged down sometimes in tech terminology, and I will try to avoid that just in case there's someone's listening who's not healthcare
so
and they're just wanting to see something outside.
That's not like a core, plastic surgeon, and that's just sort of found this podcast. This is a great opportunity for everyone. When you, at least in Wisconsin, when you turn 18, you can go to tech school and take, essentially probably a 90-hour course or something to that effect, a summer course, and get certified as an emergency medical technician, an EMT. And then there's volunteer ambulance services that you can start on, and there's some that they're not very busy. They may do one call a day, but certainly just seeing that is a good experience to figure out if that's something that you want to do. It's there's always usually senior people that are there that really sets up the potential for mentorship and just seeing what other people do. It leads into a lot of different things, medical community, whether that be, medical school, PA, nursing, that's sort of like the formal thing, or whether it leads into, police or firefighting. So that's sort of that was sort of the route that I came through. So when you asked, was medical school on the radar? Sort of. I mean, I was in those circles and trying to figure out what the right fit was for me. Quite honestly, I thought medical school was going to be too long, just medical school in and of itself, let alone residency, which, as we go along in this, the irony of all of this is,
absolutely,
is going to become apparent. So that was sort of my initial entry into the where I ultimately ended up. And so after high school, I was riding on an ambulance in the Madison area, which there's a small community called Maple Bluff, which is where the governor lives, that's surrounded by Madison, and that was the ambulance service that I was on. They covered another outlying community called Burke and Blooming Grove, and so it was a good fit. And then I did my internship. I came back to the ambulance. I also became a police officer. So the one little piece that I also left out was, in the interim, while I was going through the process to become a police officer, I also did not only the EMS or EMT certification at our local technical school, but I also did the certified nursing assistant piece. And so I worked at a hospital in Madison on a geriatric floor as a certified nursing assistant. Interestingly, it was the hospital that I was born at, which is St. Mary's Hospital. So that was
very nice.
Very nice to come back to that and go full circle there.
But sleep was not a priority for you at that time anyway.
Yeah, I mean,
and maybe just not in your life. It sounds like
I was young, and and the funny thing was, I didn't even drink coffee. Now I'm like coffee dependent. And there's Bucky.
There's your Wisconsin Badger.
Yeah, yep, and Flying W here. So very proud to say that I'm a Badger, even though I didn't go other places. But I'm happy to tell everybody always that I'm a Badger. So
I'll have to solicit some development dollars from Wisconsin. I think that would be good. A little promotion there. That was
a little promotion. This is probably they're probably going to charge you for copyright infringement.
I don't know. Yeah, I'm probably going to edit it out if they don't come up with anything.
Yes, I know. So, all right. So I went through the police academy training and then went out onto the street as a police officer. Switched over to medicine because that's really where we want to go with this conversation. So went into medicine. And then thought, hey, emergency medicine's exactly where I need to be. That's going to be perfect. I was at a community, well, not a community, University of Wisconsin, but Madison does have some issues, but it is a very high quality of life, and it is a very probably different emergency room than some of our major metropolitan areas is what I
so for the listeners who are not aware of what he's getting at, we have certain regions of the country or cities or areas which we would call gun and knife clubs, as it were, and those would be areas with high levels of penetrating trauma and other interesting things that are very stimulating for the young medical student and ER doctor. And basically, as far as I can tell, what Dr. Zuhlke is getting at is that was not so much the experience on there, more of the classy urban sort of ailments like strokes, heart attacks, appendicitis, and things of that nature. Did I describe that correctly?
Well, you are very articulate. You are a scholar and a gentleman.
That's so good. He always does this to me, and I really like it, actually. I like that. Keep it going.
That was great. It would have taken me like 5 minutes to say that. So anyway, so I actually ended up going and doing away rotations at the Grady's in Atlanta. That was very eye-opening as well, and ultimately ended up doing my prelim year in at Rush Cook County. Also one of our
Where's Rush Cook County again? And what's that like?
that would be Cook County, Chicago.
Oh, okay. Cook County, Chicago. Okay. And not to be offensive to any of our Chicago friends, but that would be more along the spectrum of the opposite of what your experience in Wisconsin was like. Would you say that's correct?
I would say that's correct, but we were in Chicago like a week ago. We love Chicago.
Of course, of course, of course.
Chicago was on our short list for places that we were going to go.
Yeah,
it's
good.
Chicago.
So don't be offended if you're from Chicago, and we happen to know that that's a very
Yeah.
violent area. So
Yeah.
Yeah.
The only negative thing I have to say about Chicago is the Bears. So
the Bears.
yeah. So
Yeah.
sorry, guys.
Okay, so
I
you're
I feel like I laid out Green Bay ahead of time, so that should not have been that shouldn't have been a surprise to anybody.
you did a nice job. So if I'm understanding this correctly, you have completed medical school along with some additional rotations, and now you're in the heart of your emergency medicine residency in Chicago. Is that right?
So
Or where are you at in the process?
let me just back up to just say, so I left University of Wisconsin and went and did a prelim general surgery year at Rush Cook County, where I met the.
So 4 years medical school. You are a doctor, and now you are an intern, kind of determining your next steps, and you're working with the surgeons at Rush. Is that right?
Oh, well, no, on June 25th, I was a medical student, and on June 26th, I was a cardiothoracic surgeon at Rush Cook County. So if anybody wants to, like trial by fire, like pick one of these types of institutions, you will learn so much, but the transition is rapid. So you still
Medical student to doctor right away.
Yeah, like right away. They're like, here's your 40 patients, be here at 4 a.m. We're going to keep passing patients out of the OR. Your job is to move these patients from the ICU to the floor to discharge. And so this was back in the day when you really did not operate as a surgical intern. You were managing.
What was your what did a surgical intern do in those days? What you kind of described it. What is the job? I mean, stuff is going on. People think surgery, they're thinking surgery, but other things need to happen, right, for the patients. So who's doing those things? I think that's what you're kind of getting at.
So our service was 2 fellows, 3 cardiothoracic surgeons, and 3 cardiac surgeons and 2 thoracic surgeons. So essentially, there were 5 surgeons, pumping patients out each day from the operating room, and your job was to get those patients and settle them. Hence the lovely Noel. Dr. Bertelson was the ICU quote chief, who was a PGY 2 at Cook County. So again,
that means a second year resident, 2 years outside of med school. Okay.
Yep. So this was the era of just transitioning from the 80 into the 80-hour work week, and so some of those regulations were on the books, but not necessarily at the time really in play.
So to clarify for everyone, the 80-hour work week, which on many surgical things is more of a myth than an idea, that was actually a rules written to decrease the amount of work to a meager 80 hours from, say, 120, 140, or however high you could go, right?
That's correct. And so these types of cultures were still being revamped at the time. And so, I mean, the dogma always was that you are responsible for the patients, which teaches you a lot. And you can have a break if you have somebody that can cover that. And then you're ultimately responsible for the patient for the entire time that you're on that rotation in 40 days or whatever. And everything has to happen for those patients to come in, get surgery, and and then leave the hospital. And so there is a lot to that, from doing their pre-op H&P, history and physical, to getting him into the operating room. The only piece that was missing for a surgical intern was actually doing surgery. But they came out and then needed everything from, management of their pressor agents in the ICU, ultimately pulling their pacing wires, pulling their chest tubes, and just moving them through the process, getting them to the floor, and then ultimately if they were going home or they were going to a skilled nursing facility or rehab. And then
So basically it was your job. All these patients had like open heart surgery or a gunshot wound to the chest or one thing or another where they had to have this life-saving surgery. Surgeries, you get them ready to go to the OR, they do the surgery, they come out, and you have to take care of every component of their care and direct the nurses to do all the stuff that they do until it's time for them to go home and see them out the door, more or less, for like 40 people.
That was it. That was my first rotation, and that was my entry into medicine.
Trial by fire, as it were.
And quite honestly, I loved it.
Yeah.
I thought it was great. So I did a year of that and rotating through the various surgical services, I think I spent 5 months at Rush Medical University, which is across the street from Stroger Cook County Hospital. I think I spent 7 months there. Learned a lot of things I probably should not have learned and not done. Then went to Michigan State in Lansing, and things were very different there. But also, so when I went to Lansing in Michigan State, that was to do the emergency medicine years.
Okay.
2, 3, and 4 years. And that it was very clear that, the world had changed from, my experience in the ER at University of Wisconsin Hospital in Madison. And this ultimately just was not what I envisioned for a career in medicine. So if at any time the question was, should I stay a police officer, that was probably the time to question it. In the meantime, I had met the lovely Noelle, as we've referred to before. I met her in the ICU at Cook County. And that was one of those things where I called her, and she was immediately said, you got to go back into the match, like no hesitation at all. And this was it. Currently, we had been synced up to finish together at the same time, and this really then put us into a real mismatch, and that later sort of dictates the way our life course went, with spending a lot of time away from your partner. So
she was going to be, you were both going to be big grown-up doctors, done with medical school, done with residency, at the same time, finish all that. Then you run into this life conundrum of, I'm happy for the ER doctors who love it. I'm not that one. I need to do something else. What should I do? And she says, now we're not going to finish at the same time anymore, but you got to pick something that's going to make you tick. And so you need to start this whole process over again with residency, and then she'll be a grown-up doctor and you'll still be training. That was the crossroads.
That's 100% what happened. So
yeah.
So for the little tidbit for the people that are out there listening, especially medical students, you can change your specialty, but it does cost you years, and it depends on how you want to do it. Yeah, I had done an intern year, so I could look for a PGY2 spot and sort of go into that spot outside of the match. But the problem is those spots don't open up until the match is over. So if you don't get one of those spots, you're waiting yet another year. And so I went back into the match and formally rematched into general surgery. And went into general surgery, and what that meant was I was starting over as a PGY1, and my partner was now a PGY4. So we ended up getting married at the end of that year, between my PGY1 and PGY, my the repeat PGY1 and PGY2 years, and then
So you were allowed to get married during residency?
the funny thing was, I had to ask them a year in advance and tell them, and then about 3 months before, uh, we're supposed to go, because our wedding was in Alaska in July. And before I was supposed to go, the program director stands up and goes, "No one is taking vacation in July." And I just sat there and I was like, because that, back in the day, that was what they said was gospel. And so then after the meeting, I walked up and I was like, I've had this vacation plan in July to get married. And he's like, "Well, we're not talking about that." No,
Oh, what a sigh of relief, huh?
like that's okay. Don't worry about that. That's different. That's not vacation,
And your heart started beating again, right?
I was like, okay, well, yeah. Or yeah, I think Noelle would have not been super happy. She had planned this whole thing for like 15 months. So anyway, yeah, my wife is from Alaska, born in Alaska. Her name is Noelle. When I met her, she had a driver's license from Alaska that said North Pole, Alaska. That's where she lived. And so we went back to Alaska to get married, which was great. Alaska is fabulous for anybody who has not been there. I definitely think put it on your bucket list. It's something amazing to see while it lasts. Okay, so I'm in general surgery. We rotate as interns on plastic surgery, and the idea here was that both Noelle and I were going to go back to Alaska and do general surgery. There are some specialties in Alaska, but not tons of subspecialists there. And so that was always, kind of the question or concern of, would it support subspecialty practice? And at the time, the answer was sort of maybe, but not completely clear. I think nowadays it certainly does. So that's just been something that has changed with the times. But anyway, I now am off sync with my wife, and I rotate on plastic surgery. And there's a guy doing DIEPs, and I'm like, this is amazing, and
So that's microsurgery where someone takes off on a breast cancer person who's had their breast removed. They take a piece of their tummy off along with blood vessels and use microsurgery to sew those blood vessels that used to live in the tummy into the chest. This is the surgery that you saw. You thought that was kind of interesting?
I thought that was pretty neat. And so
inspirational, maybe.
Yeah, inspirational. So then I called up my wife and I said, "You know what? I think I want to do plastic surgery."
I bet you got a tongue lashing for that.
No, she was like, "Great. That sounds great. Perfect." So
wow, she is an angel at every turn. I've never heard anyone say anything bad about Dr. Bertelsen. Wonderful. Just a wonderful person.
Yes, but you
married up.
You have heard people say, bad things about myself. So like we're the yin and the yang.
That's funny. Yeah. Not true.
So,
you're both yang. You're both yang.
Fair enough. So it said, "Hey, I want to do plastic surgery because it seems like a really cool thing to do." And she's like, "Great." So then, and I'll make this story short so the listeners can follow this. But so then during my third year, they decided they were going to change plastic surgery from 2 years to 3 years. So then I called her up and I was like, "Hey, by the way, it's going to be yet another year on top of the 2. Now it's going to be 3. And so then ultimately, as I was doing plastic surgery, I said, "Hey, I would like to do a hand fellowship afterwards." And so she said, "Okay." And then right when I was getting ready to do the hand fellowship, I said, "What would be great is after I finish the hand fellowship, I'm going to do a cranial facial fellowship." And then she said, "No." So that was the end.
That's
So
good.
after 11 years, she said, no more training. You have to go into practice. So, and there I went. So
So
that is,
11 years of residency, 4 years of medical school, and 4 years of college. Is that right? And plus 7 years of police work.
that's right.
That's pretty cool.
Yeah, it's a long, long story. And that's why I was like, I'm really not sure that you want me on your program.
Is it looking back, you know what you do now. You have a really cool job. We'll talk about it. Is it worth it? Would you do any turn that you would have done differently? Would you have skipped your police work and gone straight to medical school? Or would you have skipped the ER and gone straight to surgery? Or would you just do it all over again the same?
I mean, I don't have regrets about it, but ultimately being here, there definitely was a faster route to get here.
Sure.
I think that the course that you and I took, doing general surgery and then doing an independent plastic surgery residency as a second residency is becoming less common.
True.
There are more integrated programs, and I think it was effectively more equivalent, and there was some value in the 5 years of general surgery and 2 years of plastic surgery, where it ended up being 7 years. When you looked at that versus, hey, should I just do the 6 years? I think you can play that a number of different ways. Typically, the 6-year programs are going to be 2 years to 3 years of sort of general surgery and core things, which is basically how you learn how to do floor work, not necessarily master any surgery. And then you do 3 years of plastic surgery, where you're really learning and mastering surgery. I think with the other, model, the problem always was you learned how to do general surgery and fairly well at that time because it was a high volume type of residency program prior to the 80-hour work week. And there's been some unintended consequences of the 80-hour work week with case volume and things like that. But then you had only 2 years to sort of learn everything in plastic surgery, which has expanded largely. And so that I get why they went to the 3 years. If you have the luxury of time, then, what do you get from general surgery? You really have a solid base, followed by learning how to take care of critically ill patients. If you want to do, some of the if you're doing all outpatient plastic surgery, you probably don't need to know how to, take care of a critically ill patient. If you're doing limb salvage and, high level reconstruction stuff where you're dealing with sick patients and patients that have cancer and things, that general surgery base really provides things for you. It's nice to see the other side of breast surgery when you're doing the mastectomies, when you're
right.
later going to do the reconstruction, when you've done the APRs and the LARs, if you're going to do the VRAMs and pelvic reconstruction, it's good to be on that other side as well. And so it's one of those kind of things where it's really hard to look into the crystal ball and know exactly what you're going to do down the road to set yourself up. I mean, if you were going to do all facial plastics and, head and neck type things or head and neck reconstruction, then doing an otolaryngology fellowship ahead of time is really great. There's also a tract that very few, but there are some urologists that are plastic surgeons, and they actually even have their own little tract of reconstructive urology. And then the last two other segments. So we've talked about general surgeons that go into plastic surgery, otolaryngologists, urologists, also who qualifies as orthopedic surgeons, and neurosurgeons. I don't know that I've ever met a neurosurgeon that's been also a plastic surgeon, but there are
not
some neurosurgeons and neurocranial plastic type movements that are there. I've met I think one or two orthopedic surgeons that have gone on to do plastic surgery. And if you're going to do limb salvage and extremity work, I mean, that's an awesome combination. to have that. So, I was a little bit mixed on what I wanted to do. And so, the base that I got, really solid general surgery training, at Mayo Clinic. And then I went to University of Nebraska, which is where I met the, world famous Steffen, Dr. Steffen. So this out.
Infamous.
Yeah, well, anyway, that's where we met, was the University of Nebraska. And then I went on to do an orthopedic hand and upper extremity fellowship at the Hand Center of San Antonio, which I, to this day am honored to have had that experience. The big names that are there were Dr. William Peterson or Chris Peterson, and then obviously Dr. Green. But the interesting piece to that was their whole group was amazing down there, and some of the sort of unsung people there continue to be, the people that I really look up to for how they've done their practice, and who I call for questions. So I want to mention everybody that's there: Dr. Bag, Dr. Person, and Dr. Srinivasan. And then my co-fellow, Kunj Desai, stayed there, and we continue to communicate over the years, and that's been really amazing as well too, to have a peer that's doing something different, or that's you have that ability to see where they're moving in practice and where you're moving up in practice. I think he still does a lot of plastic surgery, but obviously has a higher focus on hand. I think I have a higher focus on plastic surgery, and still do some hand surgery. So.
Yeah, well, it's neat to see, and I think some of what you're sharing is that interplay between plastic surgery and other specialties, talking about, how if you read chapter 1 on plastic surgery text, you have, some people talk about it being a finishing specialty, or the person, you're kind of wrapping up at the end. Say the general surgeon has removed the breast and we go reconstruct it, or, it's getting to be a little bit of a thing of the past, but plastic surgery techniques, we were the people replacing the jawbone with the leg bone using microsurgery after the ear, nose, throat, or head and neck surgeon put that back together. Or say someone has had a devastating motorcycle injury and their leg is mangled, and we use microsurgery to preserve that leg. You mentioned that limb salvage or keep that. And so that's one of the things that I enjoy, and I think I'm picking up that you do too, about plastic surgery, is sometimes that interplay with other specialists as well.
For sure. I like being in solo practice and having the autonomy and making the decisions, but I also enjoy working with my other specialists. And that's sort of the capacity that often you can be in or are in, especially as a reconstructive surgeon. We typically will talk to patients about the ablative phase or the extirpative phase, where they're removing, the cancer, and that's the cancer treatment phase with, either neoadjuvant or adjuvant therapy, and then moving into the reconstructive phase. And only to jump the script here for you,
Thanks.
One of the things is why plastic surgery. I didn't love dealing with patients that were dying, and that that in many other specialties is a central focus of obviously we want to try to improve people's quality of life, take care of ailments, but there's a certain component where the cycle of life, or whatever is you refer to, is that there is a phase where patients die, and that was like, I'm okay with it, but it wasn't like I didn't go into palliative care. There are people that are really, really good with that phase of things, and it's really a passion for me. I really love the standpoint. The dogma always for plastic surgery is form and function, and basically improving patients' quality of life, whether it's from a psychosocial standpoint or whether it's from a physical standpoint. And that was a very positive thing for me, particularly coming from policing. So that is one of like the big. There's two big differences that I would say from policing. One is when you're policing, you've got skin in the game. You as a police officer can get hurt or something bad can happen. Really, as a doctor, it's very rare that you would get a devastating needle stick that's going to harm or injure you. You could get sued, which is not good, and you can get sued as a police officer. But ultimately, at the end of the day, when you do surgery, you don't feel the pain. It doesn't hurt you.
Right.
That outcome, it's not you. So that is one big difference that's there. But the other big difference is you're talking to a very small segment of the population that as a police officer that has different interests potentially than you do. They're mad at you. They like to lie to you, just like it's not a very positive or progressive conversation. Whereas, with working with patients, sometimes there's conflicts between doctors and patients, but the reality is they're coming to you, and you're trying to work together, is in a shared manner to, improve something together. So it's very cooperative as opposed to adversarial. And that is great. And plastic surgery, I think, is really that way as well. Patients come to you and place a tremendous amount of trust in you sometimes when they're having really, really bad things happening, as you alluded to, cancers or devastating motorcycle injury with the potential for loss of a limb. I really strongly feel that we have an obligation to try to really sort of police ourselves, to say, hey, this is what we think we can offer, and not over-promising, and not, stepping away from our obligations of what we were trained to do. And that's sort of where my practice has fallen in. There are always like a bunch of conflicting things that happen in practice, and from the standpoint of where goals are sometimes skewed based on all kinds of different things like insurances and payers and how much work it's going to take, and what pays more, and how do you keep your doors open. I mean, none of these are necessarily where people are out to do something bad or sinister. It's just that there's a lot of dynamics that play into how we deliver care. And
a lot of things distract from your goal, the reason you got into medicine in the first place, which is to help people. There's a lot of things that want to naturally distract from that goal, right? Easy distractions.
I think so. I mean, we to go back to 9/11 era, it was very interesting to see people very much willing to give up their civil liberties for the sake of fear or safety. And to put an example there, I think safety is appropriate and reasonable, but people that coerce other people based on fear is probably not right. And so, I mean, those are the same sort of ethical and moral decisions that we make as surgeons and how we deliver care. I think that come up, and they're not, they're just out there. For the folks that are going, just going to medical school, it's always funny when we see somebody new going to medical school, like we've got one of our au pairs is in a relationship with somebody who's going through medical school, and we went to somebody's wedding who was just going into medical school, and they're very, happy and, really like, have this great, the things that people need to take into medicine about this being great. And we're sort of like, should we just let them figure all this stuff out on their own, or should we just like ruin their like, ruin it right now and tell them how awful it is? I mean, it's the other things that I think if you ask any physician, the core things that everybody went to medical school for and the ideals that they had, those are the things that still drive them. But then there's all this other stuff that all of a sudden you learn about, as you go through the process and what actually has to happen for the true delivery of care, day after day, week after week, month after month.
Yeah. Well, I think it's interesting to think that the distractions are there, and we know the downsides of medicine. But you answer the same as I think most of physicians that I would speak with or know would say, is that they would still do it all again. So for the prospective medical people, on the one hand, you don't know about some of the things that are coming, and that's okay. That's probably for the best. But at the same time, in spite of all those, it's still very gratifying. Am I right? Would you agree with me on that? I think you would.
Well said.
Thank you, sir. Hey, before we go on to the next segment, I wanted to ask a little bit more about just kind of at-home life, what you're up to when you're not doing plastic surgery. Do you have any kids? What's Dr. Zuhlke doing when plastic surgery is, and you work a lot, I know that. When you're not working, what are you doing these days?
We try to spend as much time at home. Our kids at 7 and 10 have a lot of activities. They've sort of graduated from, being home to now us being the chauffeurs and driving them to all the various different things that they do. They're very active in Colorado Children's Choir, and then they also play some sports, some tennis and soccer. And they may, we may expand on that. At this point, we're still trying to do, survey of everything. So whatever they have interest in, doing those types of things. We like to spend time at the community pool in our neighborhood during the summers, do hiking and get outdoors, and then skiing and snowboarding during the winter has been great. And so Colorado has been great for us with really a lot of outdoor activities, 300 days of sunshine. And so that has been very good from our standpoint. And I think our kids dictate what they're interested in doing, and that's kind of, we follow suit. We try to come up with, progressive, different types of activities to stimulate them and see what they like at this point. And I'm sure they'll settle into certain things. We also like to travel, and whether it's traveling for a meeting, or, as I said, going back to Chicago to go through our old stomping grounds, which have changed some, but still manage to be recognizable, is very, very pleasant.
That's cool. Plastic surgeon and family man, Dr. Zuhlke. I would love to hear from you, Dr. Zuhlke, a little bit about your practice and what is your plastic surgery practice like in the Boulder, Denver area.
My practice is pretty broad in just kind of starting from the top. I do still a fair number of scalp reconstructions and things with neurosurgery for, all of the things when they're doing, needing to do cranioplasties, or when we have, skin cancers that go to the depth of the bone. And we, where we have to do some of these types of procedures, or there's wound healing complications related to radiation. And I'm not sure that there's a lot of other places out in the community. We kind of Denver's sort of divided with Highway 70 running right through the middle, and then there's north and south, and then the Highway 25 has east and west. And so kind of in this northern portion, there are some other people that probably do some of these things, but again, practices are far enough spread apart that in this area, a lot of these things, there's not anyone else to really address these issues. And so from the standpoint of delivery care to the community, we ask these questions of, do we need to do this? Is this reasonable to do this, or does this need to be sent someplace else? And obviously, the idea is to try to, and mainly for patients' sake, patients don't seem to be inclined to want to travel or to go into new and foreign systems.
Right.
So those are all the sort of the dynamics that are, at play. I do some work with neurosurgery and spine surgery for back wounds as well. We do a segment of aesthetic surgery. In my practice, I've gone from doing about 90% aesthetic surgery, so starting out doing reconstruction and then going up to about 90% aesthetic surgery, and now dropping back down to doing 10 to 20% aesthetic surgery in my practice, and really more reconstruction at this point. But reconstruction is hard, and it's really hard with the reimbursement, and interacting with insurance company has not gotten any easier with time. It's gotten more difficult. And so we do aesthetic surgery, obviously with the general surgery background. Breast and body are really my bread and butter for doing aesthetic surgery. We do those very well. And then I do some.
Tell people, I know personally that you have a lot of expertise in high def liposuction on the cosmetic end. Tell people a little bit about there. I think the average community person does not know what that means, or even what's possible or has even necessarily even heard of high definition liposuction. What is that, and where can that go wrong from someone who does it, who doesn't know what they're doing, compared to kind of the results that you feel like you can reliably deliver?
Yeah, high def or three-dimensional liposuction it's sort of the next generation or the next iteration, and it's been around for a while. It's just
it's not new, right?
Yeah, there's always a learning curve to adopt new technology and new techniques, and we always talk about the cutting edge versus the bleeding edge. Where do you want to be on that? Do you want to be way out in front of the curve, which means there's potential unintended and unnoticed complications that are going to arise that you're ultimately going to have to innovate and deal with, versus kind of seeing as other people have their experience and shares their experience. This is what's safe and reasonable, and this is the technique to do, and this is the reliable result that you can depend on, from that standpoint. So going back, I mean, and I'm sure there'll be a liposuction expert out there that disagrees with my nursery rhyme version of the evolution of liposuction, but liposuction was initially tried by an OB-GYN with dry liposuction, and it was a disaster with a lot of bleeding. And then eventually tumescent liposuction came about, which was essentially putting in fluid plus lidocaine plus epinephrine to control both pain and bleeding. But I think probably, patients were asleep. It was an under anesthesia procedure, and that's how it was when I was in training most of the time, as I went through. And then a cannula was simply put in, and the fat was sucked out. Then some people got a little bit more sophisticated on what sort of the process was, which became this term, safe liposuction, which was an acronym, which was fat separation, aspiration, and then fat equalization. And so, so then people were starting to think about this a little bit more, and one of the dogmas in the past was you only do deep liposuction, don't get up by the skin. And I don't know if people really understood the anatomy, but at a basic level, the anatomy is that throughout our body, we have this superficial fascia, or Scarpa's layer of fascia. which defines kind of these different layers. And also patients have different distributions, and based on all kinds of things, just their body type or, genetic, whether they're male or female, whether they have intra-abdominal or extra-abdominal. And so really with liposuction, as people became more students of the game, they started to do better analysis of, what are we actually going after? Not everybody who has a large abdomen is the same. And so, now when we look at our layer, our superficial fat layer, so the extra abdominal layer, we're really dividing that into at least 2 layers. And there's some people out there that say there's 3, but at least 2 layers, with a deep fat layer below the superficial fascia and a superficial fat layer above the superficial fascia. And in doing liposuction, with traditional cannula-based traditional liposuction, you're basically taking a cannula that has some sort of ability to not only sort of cut the fat free, but then suction it up. And so it's all sort of one process, and manually the cannula is being moved by you.
So it's a long tube with some shape of hole on the end of it that both, like you said, kind of separates the fat in some capacity from the other fat, and then also allows you to suck it out through the hole with a suction tube connected to the end of it in one way or another.
And so the way that the cannulas were made were determined how aggressive they were, also the diameter. And so there's a lot to that as well. But if you use essentially, a large diameter suction cannula, liposuction cannula, you can extract a lot of fat rapidly, but it's also, the difference between coloring with a broad, thick marker versus a fine tipped, small marker. And I mean, it's really as simple as that. And that's where things got, led to uneven liposuction, is, essentially trying to do this too fast, not going back for the fat equalization, moving from the deep fat plane to the superficial fat plane. And the superficial fat plane is very unforgiving, especially with the large cannula, and led to, the ripples and lumps and bumps and stuff that people quote referred to as, bad liposuction. So that was sort of that initial move into liposuction. And then what is not really new anymore, but we still sort of consider new technology, is the energy-based devices, and those have come in lots of different varieties. The one that we typically use is Vaser, which is ultrasonic energy, and partially you get to where you become very facile and just are able to anticipate what's happening, and that becomes your tool of choice. I think there's certainly people out there that will debate, what is the best, but from the standpoint, the idea of delivery of energy is to help with separation of the fat, so that it's actually broken down into a couple of different phases. First phase being separation of the fat, and then coming back and extracting. So an extraction phase after separation. So the Vaser, from our standpoint, it causes less trauma, and it does not lyse the actual fat cells. So the fat cells themselves stay intact, and they basically the Vaser breaks it up into clumps of about 20 to 40 cells, which then makes it easier to extract during the suction phase. And what that also means is, instead of sort of ripping the fat out, it's already liberated and it's just being sucked out. So less bruising, less pain, faster, recovery times, and also a greater quantity of fat extraction. So, potentially up to 50% more fat extraction. So this has been a very effective technique for us. And then going back to, this manual liposuction, which was always the Tom Sawyer at Mayo Clinic, which was, hey, I was foolish enough to think that they actually wanted to teach me plastic surgery, but they're like, oh yeah, you can come and do liposuction with us anytime. And it was just like, painting the fence. It was the free labor of like, I mean, it was a great workout. I will tell you, it was fantastic workout for your arms, but it is labor intensive. So what has happened since then is that, there are machines. The specific one that we use is a machine made by Microair called power assisted liposuction, PAL, which is a very common one. But effectively, there's a motor in the handle that is oscillating the tip. And so, every single limited pass that you make is like making 100 passes because it's oscillating the whole time. And so this really has sped up liposuction, and then as we've learned more about what are the good limits for toxicity with lidocaine and the differences between placing lidocaine in a sub-Q fashion versus placing it intravenous, it's allowed us to develop a good regimen for doing wide awake liposuction. So 90% of our liposuction is done with the patient awake, which is it's actually sort of fun. You talk to the patients much like this. Maybe I should have my own wide awake liposuction podcast.
There you go, something to think about.
Yeah. Well, we talk to the patients. We would never do that because we do give them some medications that sort of inhibit what they say. But then obviously they're fun conversations sometimes. But what gets said obviously stays in the procedure room. But we listen to music, talk to patients, learn about patients, and we actually get to spend more time with our patients, actually conversing and getting to know our patients than what you would typically get to in a consultation where you're trying to move patients through rapidly. We spend a good 2 hours with them, talking about them and learning about stuff, which actually has been enjoyable. I initially was, I think concerned about, having to talk to the patient or the patient being awake for 2 hours. But most of the time it's a super pleasant, just interaction, makes the day go by fast. So I've actually enjoyed that. So we do wide awake liposuction, and this is sort of the just groundwork. And I've kind of told you about at least 2 iterations or 3 iterations. The next iteration after that was, hey, okay, so now we've got these techniques where we can actually really target, the fat in the areas that we want to, target. What happens if we, now can we do something more? And the question in the past, this 3-dimensional liposuction was sort of like, oh, in quote etching, are we just going to like make, sort of these fake muscles on people? And I guess you can do that, but really what the idea is liposculpting. So where do we want more fat? Where do we want less fat? What if we leave certain fat here and take certain fat there, do we accentuate things? And so we talk about sort of the mountains and the valley, right? So fat grafting has been this next adjunct to it as well, which is not only can we just take away at certain places and create valleys, now we actually can add fat in other places to create mountains. And so that's that change in contour and contrast is really where you see that definition start to come out. And so when we talk about doing body sculpting, depending on what patients want, you may want to accentuate the hip, so you want to take less fat there. But as you go up, towards the costal margin, people may want their waist taken in, or in a male, there are certain principles that are there. Typically, it's almost artificially accentuated in males that and this is very stereotypic as we. The idea is that when the patient comes in there, they choose what they want and how, what kind of definition and styles that they want. But if you were to ask, sort of just black and white, stereotype. Males are going to want more squared off, so their pectoralis muscles squared off, which may or may not be actually truly anatomic or natural, but that those tend to be associated with more masculine shapes and round and curved, more feminine shapes. But you'll also have, somebody come in who's a big weightlifter who's like, I want to see this definition in my abdomen, a female, and that's fine. This is the great thing about liposuction and liposculpting is, the patient gets to choose what do they want. So I think as long as it's reasonable, or that you've really had a long conversation about what the outcomes and unintended consequences are for something, and I find that most of my patients, this is not a struggle to have with them when you say, yeah, you don't want to do that because that's actually going to drop your buttocks and make your buttocks small. We really want to accentuate this. That they're very, sort of like, oh, okay, yeah, you're the expert. They're sort of willing to defer to that. But it's always good to have, we always want their input, and we try to take patients' input, to heart to deliver what they want, because in the end, that's how you get a satisfied patient, is delivering good results. So, those are some of the things, and it's been fun because this was not a technique that I was necessarily trained in or was around when I was in training, and so has been a great adjunct to my practice. And we still use these techniques even when we're doing reconstruction, and that has been so. I'll share a story with you from residency. I went to the University of Nebraska to interview, and I was asked by the program director, who was a cranial facial peds guy, which I didn't realize was doing aesthetic surgery like every Wednesday. And he asked me something about, what do you want to do? And I said, well, reconstruction. And I truly meant that. Like I was truly sincere. I think there's a lot of people that really want to do aesthetic surgery, but I was like, no, the reason I went into plastics and, in my whole story of telling my wife, yeah, I'm not just going to do general surgery, was like, I wanted, to do these amazing reconstructive surgeries. And so I felt I was being really genuine. And then he said something about, well, what do you think about aesthetic surgery? And I'm like, well, I think that it's, you need to learn that, but I'm more, interested in reconstruction. And he just about jumped over the table and he's like, aesthetic surgery is important in everything we do. Aesthetics is important in everything we do. And I was like, oh, okay, I'm not going to match here. And ultimately I ended up matching there. But I thought that was the end of the interview. But point taken going forward, aesthetics is important in everything we do, because
that's true.
Aesthetics is good. Your reconstruction is good because it's form and function, right? So you don't want to just slap a big piece of tissue on somebody's leg and have it be this massive, non-contoured, type
one disfigurement to the next, right? That's not what we're shooting for.
Yeah, that's not what we're shooting for. So, I think that, when people are looking at plastic surgery, it goes really hand in hand of aesthetics and reconstruction. When your reconstruction is good, your aesthetics are better, because I think you really understand the anatomy with reconstruction, because you have to. And I think with reconstruction, when your aesthetics is good, your reconstruction is better. And so I don't think that you can separate the two. I think that was a really appropriate statement, that aesthetics are important in everything that we do. That's always those two always are hand in hand. The question is, you're doing one or the other, where is your priority at? And, what is your list of, what is the most important thing you're going to do? What's the second most important thing? Third?
Yeah.
Fourth?
I agree completely. And I think that's a common public misconception, which is the arbitrary separation of reconstructive surgery and aesthetic surgery. And of course, they are totally friends. And I like to use the example of cosmetic breast augmentation and breast reconstruction after cancer. The motivation for receiving either breast reconstruction or cosmetic surgery of the breast is essentially identical for the breast cancer patient, and that it's just the way to get there is obviously unfortunate for the breast cancer patient, but both of them would like to feel normal, you know.
Agreed.
I don't know. That's my take on it. Just an example that's a little bit more edgier because people have more opinions on that topic. But you're like, well, if you think about it for too long, you're like, no, this is off. Most of it, I would say that's not totally across the board, but for most patients, that's the case.
Yeah, I mean, and I think you and I have had this conversation before about, the psychosocial benefits of any type of procedure, as well as sort of form and function, and that falls under this sort of function standpoint, which interestingly in the United Kingdom, everybody gets essentially, I said DSM-4 and my wife was like, they're on DSM-6 now.
Yeah, I was going to say, yeah.
And so, but essentially they have to have a true diagnosis of something that falls within whatever, here in the US, it's DSM-6. We thankfully have a diagnosis of Z41.1, when a patient just has dissatisfaction with their aesthetic opinion, that we're not questioning that this is causing some sort of dysphoria. They just, as a person and sort of autonomous self, so one of the tenets of medicine, obviously, here is, self-autonomy. And so that, a patient can say, this bothers me and I want to correct it. It might not be causing me, not to be, I can still leave the house, but I want to do something about it, versus, sort of this actually having to go through a psychiatric diagnosis or having a psychiatric diagnosis placed in order to proceed to aesthetic surgery. So that, that is an interesting piece that's, here for us. And so the question is, the psychosocial benefits of this, and this is all very debatable, but there's a lot of things out there from, reduction in depression, reduction in suicide rates, and not necessarily from aesthetic surgery, but in general, when we're talking about, a certain one, these essential dysphorias or things, or dysphoric attributes or characteristics, that something may, and I think that's why I said it's a slippery slope, because it's a gray area. I mean, you sort of either say, yes, we do believe that, restoration and, improving form does potentially have a psychosocial benefit to patients. And I think this is very well accepted from the breast reconstruction standpoint, where we accept that reconstructing the breast mounds does allow reentry and more participation, or less anxiety in society, and that is real. As we get into some of the other types of surgeries and stuff, that there's often this, and even we see it with hospital administrators and things like, well, that's not really an important surgery, type of thing. And it's sort of this assumption that, everything is just a purely cosmetic type of surgery. And I think that's a hard one to basically raise awareness to. As I said, I do, 90% of reconstruction, and I'm credentialed at a hospital, and the surgery center would not credential me because they didn't have aesthetic pricing. And I was like, 90% of my stuff goes through insurance. And then I told them so as I've sort of alluded to the audience. I'm triple boarded in general surgery, plastic and reconstructive surgery, and hand surgery. And I was like, well, then credential me as a general surgeon there. And that still didn't work. So, but the presumption was that all we were going to do is bring, aesthetic patients there, that this somehow was not fulfilling a community need. And I found it interesting because the majority of what we would bring there would be, cancer reconstruction, which I think most arguably, people do sort of buy into that. Hey, you shouldn't have a massive, hole in your forehead or missing part of your lip or, missing a portion of your nose, that reconstruction is appropriate. But at the same time, it may not change the function of how your nose or your, forehead works. And so I think that phrased in those terms, I think people then do sort of say, oh, okay, I do agree that there is psychosocial benefit to those things. But at the same time, even though they're under reconstruction, largely they're for, reparation of, an aesthetic deformity.
All right. Closing things. Anything in particular you want prospective patients or people to know about your practice?
Well, we're certainly here, and we're happy to see new patients. I really just want to take the time to thank you for doing this. I think that this is a good way to, in a new, wrinkle on outreach to patients. And I think that's the biggest issue here is, to some extent, we all went into this to be not only surgeons, but and do procedures, but also to provide people with, education. Again, back to my initial statements of we wanted to work with people and help people. Providing education is certainly one of our, tenets of how we can do that. And, we're not always the right surgeon or practice for patients, but hopefully they gain some knowledge along the way.
If you enjoyed today's conversation, be sure to subscribe so you never miss an episode. You can learn more about my practice, explore additional educational resources, and find all of our podcast episodes at calebsteffenmd.com. You can also follow along on social media at Caleb Steffen MD for surgical education, behind-the-scenes content, and updates on future episodes. If you found value in today's discussion, we'd be grateful if you left a rating and review on your favorite podcast platform. Your support helps us reach more surgeons, trainees, and anyone interested in the field of plastic surgery. Information shared on this podcast is intended for educational and informational purposes only. It should not be considered medical advice and is not a substitute for consultation with a qualified healthcare professional. The opinions expressed by guests are their own and do not necessarily reflect those of Dr. Caleb Steffen or this podcast. If you have questions about your own health or medical care, please consult your physician. See you next time.